So we are now going to cover Board Review Practice 4 for IRM 2020. These are my disclosures. So question 21, and picking up from our last session, this patient pulled out a tick from her skin 30 minutes after a trek in a conservation area in Barnstable in Cape Cod, Massachusetts. And the question is, what is the most likely diagnosis? And what you see on the left is the tick, and the options are A, bed bug bite, B, deer tick bite, C, kissing bugs, D, deadly brown recluse spiders, and E, flea bite. So the correct answer is deer tick bite. Let's just now look at the background to this. So clearly, there are many different types of ticks. There are bed bugs. This is a bed bug on the left-hand side of the screen. There are fleas. Fleas are wingless with mouthparts adapted for piercing skin and sucking blood. On the right-hand side, deadly brown recluse spiders. Neither of these options is correct. And the bottom here is a body louse, which is a female shown here, and cockroaches, which obviously are very large or relatively large, and that's not relevant here either. This patient has a deer tick, which is shown on the right-hand side. This is the typical appearance of a deer tick. You might find this in the woods while you're playing golf or gone for a walk in the northeast part of the United States. This map here shows the black area where deer ticks and Lyme disease endemic, some aspects of the Midwest as well, but mostly it's in the Northeast and perhaps a little bit on the Southeast of the United States. Some facts about Lyme disease, because the deer tick commonly transmit Lyme disease, although not exclusively so, as we'll discuss. So Lyme disease is the most common tick-borne infection in North America and Europe. In the United States, Lyme disease is caused by Borrelia burgdorferi, and is transmitted by a bite from the tick species Ixodes scapularis or Ixodes pacificus, and the clinical manifestations commonly are manifest in skin, joints, nervous system, and the heart. The early cutaneous infection with Borrelia burgdorferi is really erythema migrans, and I think that because it's very common, this is the one you should be most watchful for if someone presents early. Ixodes scapularis may also be infected with and transmit Anaplasma phagocytophilum, previously referred to Ehrlichia phagocytophilia, and or Babiosia microti, the primary cause of babiosis. So bite from this type of tick may lead to the development of Lyme disease or human granulocytic anaplasmosis, HGA, formerly known as granulocytic auriculosis. All of this are quite a mouthful to say. And babiosis as a single infection or less frequently as a co-infection. And so HGA and babiosis should be included in the differential diagnosis of patients who develop fever after an Ixodes tick bite in an area where these infections are endemic. I want to share with you the latest draft guidelines of the IDSA, the Infectious Disease Society of America. And what they recommend in these draft guidelines, which were circulated in the fall of 2019 and are not in final form yet, let me just add, are the following: that you should consider prophylactic antibiotics. A single dose of oral doxycycline should be administered to patients within 72 hours of removing a tick after a high-risk tick bites, but not after lower-risk tick bites. And how do they define high-risk tick bites? They must meet the following criteria. They must be from the typical tick, which we've seen an example of. It be in a highly endemic area, so obviously in the Northeast would be the most highly endemic area, and from a tick engorged and attached for 36 hours or more, and that will probably take some careful history taking. You may have none of these, and you may be suspicious of these, and so therefore have to think about oral doxycycline as an empirical treatment in someone who has some but not all of these features, because not everybody will be able to look at the tick and be able to establish that it was attached for 36 hours, etc. For patients with an erythema migrans, the preferred treatment include 10 days of doxycycline or 14 days of amoxicillin or cefuroximine or phenoxymethylpenicillin. Now, there are more established guidelines which date back many years, 2006, for example. And these, I should mention, because if you're sitting the boards, these are the ones that will probably be tested in the boards, are the following. For early localized or early disseminated Lyme disease associated with erythema migrans, in the absence of specific neurological manifestations or advanced AV heart block, then you should consider doxycycline 100 milligrams twice daily for 14 days. So it's different in the most latest iteration, which is for 10 days. Amoxicillin, 500 milligrams 3 times a day for 14 to 21 days. So again, in the more updated guidelines, it's for 2 weeks. In the more established, somewhat dated guidelines, it can be as much as for 3 weeks. Cefuroxime for 14 to 21 days at 500 milligrams twice a day. Doxycycline has the advantage of being effective for treatment of HGA, but not for babiosis. And remember that HGA may occur simultaneously with early Lyme disease. Remember that doxycycline is relatively contraindicated during pregnancy or in patients who are lactating and or in children who are under the age of 18 years. This table from the source here shown cited at the below divides up Lyme disease into 3 clinical stages, stage 1, which is early localized, stage 2, early disseminated, and stage 3, late chronic. And obviously the most common manifestations of Lyme disease that you'll probably see are in the early stage 1 localized disease with, as we discussed, the commonest manifestation being erythema migrans. These patients may have accompanying myalgias or arthralgias, headaches, and flu-like symptoms, and perhaps even regional lymphadenopathy. Stage 2 and stage 3 are also mentioned just for your review. Let's move on to the next question. This is question 22. A 62-year-old woman on dialysis undergoes a total parathyroidectomy for tertiary hyperparathyroidism, a PTH of 1200. Postoperatively, that's approximately 6 hours post-op. She complains of tingling around her lips and around the mouth. Approximately 9 hours later, she has carpal tunnel. Both Trousseau's and Schwastek signs are positive. And an EKG is done, and I'll share with you these pictures in a minute. But what we'd like to know is which one of the following is most consistent, which one of the following EKG manifestations is most consistent with her likely serum calcium level. So take a read and say, given this clinical presentation, what is likely to be the serum calcium level, and then what is the associated electrocardiographic manifestations with this calcium level? So these are the 3 tracings. A, B, and C are your 3 options at the top. And you see in A, for these leads, 1, 2, and 3, the limb leads, the QT here is 0.48 seconds with a QTC of 0.52 seconds. In B is QT of 0.36 seconds with a QTC of 0.41 seconds. And then in C is 0.26 seconds and a QTC of 0.36 seconds. So if you think B is the middle of these two, one is higher, the QT, one is lower than what B shows. Correct answer is A, and in A, you see this patient has a pattern compatible with hypocalcemia. The clinical picture is consistent with hypocalcemia. A patient had a parathyroidectomy, you had removal of the parathyroid gland, so the scenario, context is you're likely post-op to see severe hypocalcemia because you have a hungry bone syndrome where all this calcium fluxes back into the bone. And then on top of that, you have clinical manifestations, Schwastek and Trousseau sign, but also carpal spasm. So then the question is, what is the manifestation of hypocalcemia? And here what you're asked to look at is the QT interval. And you can see in hypocalcemia, the QT interval is contracted or shorter. This is normal, and hypercalcemia, it is prolonged. So the electrocardiographic changes in hypo and hypercalcemia are depicted in, or the facts are depicted in this slide. Hyper and hypocalcemia predominantly alter the action potential duration on the electrocardiogram. Hypercalcemia shortens the ventricular action potential duration by shortening phase 2 of the action potential, whereas hypocalcemia prolongs phase 2 of the action potential. Hypercalcemia, therefore, is associated with a short QT interval, and whereas hypocalcemia associated with a longer QT interval. Just to bear in mind that in hypercalcemia, you can also see a decreased T wave amplitude, sometimes with T wave notching or inversion, and you might also see a high takeoff of the ST segment in leads V1 and V2. These leads were obviously not shown in the picture that preceded this slide, but this picture may simulate acute ischemia. Remember that hypocalcemia generally does not cause T wave changes because it does not affect phase 3 of the action potential. Question 23, we see an eye here, and the question is, what's the diagnosis? A, lead toxicity, B, copper toxicity, C, zinc toxicity, or D, mercury toxicity. And so the arrow here is showing you the Kaiser-Fleischer ring. The diagnosis here is copper toxicity in a patient with Wilson's disease. So some facts about Wilson's disease. Wilson's disease is also termed hepatolenticular degeneration. It's an autosomal recessive disease with the mutation of Wilson's disease protein gene ATP7B. You do not need to know this much detail for the boards, but this ultimately results in accumulation of copper in various tissues around the body, specifically quite a substantial accumulation in both the liver and the brain. The disease was named after Samuel Wilson, a British neurologist who first described the condition in 1912. A single abnormal copy of the gene is present in 1 in 100 people who do, in fact, who do not develop any symptoms. These people are termed carriers. But if a child inherits the disease from both parents, homozygous, the child may then develop Wilson's disease. Symptoms usually appear between the ages of 6 and 20 years. And the prevalence of this disease, Wilson's disease, is 1 in 4 per 100,000 people. Here you can see in this schematic some of the clinical manifestations. The liver is very prominent, the eye is very prominent, and the CNS system is very prominent. Other systems that may be involved in where copper accumulates might be the kidneys, manifesting as proximal renal tubular dysfunction, and the heart manifesting as a cardiomyopathy hematologically, with hemolysis being evident in the bone with arthritis and rickets. But it's really the liver with hepatomegaly, jaundice, acute hepatitis, and so on, ultimately culminating in cirrhosis, portal hypertension. That's a key clinical player. The eyes, you see this Kaiser-Fleischer rings that I shared with you, and then the nervous system with deterioration in school performance, behavioral changes, lack of coordination, resting and intention tremors. Question 24. A 48-year-old white male with chronic kidney disease, CKD, has a creatinine of 1.5 milligram per deciliter, presents to you complaining of weakness and fatigue and an episode of palpitations. The patient is on furosemide 40 milligrams BID, lisinopril 20 milligrams QD, atorvastatin 20 milligrams QD, and aspirin 81 milligrams QD. You do an electrocardiogram, and I'm going to share with you that on the next slide. So you do an electrocardiogram and you draw labs. Based on what you will see in an electrocardiogram, you're asked to make a diagnosis. Does the patient have hypomagnesemia? Does the patient have hypokalemia? Does the patient have hypercalcemia? Or does the patient have hypocalcemia? So A, hypomagnesemia, B, hypokalemia, C, hypercalcemia, and D, hypocalcemia. This is the electrocardiogram, the leads 1 through limb leads, and then you see them here. And the question is, what does this patient have? So I'll give you a few minutes to just look at the electrocardiogram carefully. So the correct answer is this patient has hypokalemia, a potassium in the, you could think of it around 2 milliequivalents per liter. So just to go over this, this is a normal electrocardiogram shown in the upper left-hand side of your slide with the normal QRS. Focus yourself on the T wave. In hypokalemia, you'll see this prolongation, and then you see this U wave. Hyperkalemia, you see this pinch bottom T wave or peak T waves, and particularly will be seen with potassiums in the higher than 6.5 milliequivalents per liter. In the bottom two tracings, you see hypocalcemia, we've covered that, and hypercalcemia, which we've also covered. Normal kalemia shown here, you see the normal QRS, and you see this very minimal, if not even discernible, U wave there. Whereas in hypokalemia, you see a very prominent U wave. These other manifestations are there probably for the books, but the thing you need to remember, clinically relevant as well as for the boards, is this prominent U wave appearance. And so when you go back and look at the electrocardiogram here, you see this prominent U wave here. It's seen here in V3 and in this chest lead. This is actually the limb lead 2, but you see that in prominently in V3 here clearly. So in PR, so in summarizing hypokalemia, the PR interval may be prolonged. There's a flattened T wave, a prominent U wave. There's ST depression and QT prolongation, but it's often difficult to measure as the T wave flattens. But the key thing, the key learning is the prominent U wave. Next question. This is question number 25. This is a 55-year-old man, shown in the picture of him on the left-hand side, who presents with a 2-year history of painful jaw enlargement and progressively ill-fitting dentures. The serum level of alkaline phosphatase and bone-specific alkaline phosphatase is elevated. So this would be, in this patient, it was 154, with the normal level being less than 120 for the alkaline phosphatase, and then for the bone-specific alkaline phosphatase, 92 with the normal range 15 to 41. So, and you see this patient, I think I just want to point out the square jaw here, prominent square jaw, which is something you should bear in mind as you think about the differential diagnosis and the associated tests you might need to work out what this patient has. And so the questions you have is, which one of the following tests would confirm the diagnosis? A, bone scan; B, insulin-like growth factor 1 level; C, serum calcium; D, abdominal ultrasound; and E, testing the function of the facial nerve. And the correct answer is A, bone scan. So this patient has Paget's disease. This patient, has Paget's disease, but the differential diagnosis includes Paget's, acromegaly, and renal osteodystrophy, because all of these three could potentially explain the jaw enlargement that's visible on the image. So I highlighted that for you. So as you think about jaw enlargement, think about Paget's, acromegaly, and renal osteodystrophy. But the alkaline phosphatase, the elevated alkaline phosphatase and the elevated bone-specific alkaline phosphatase are the telltale pointer to the diagnosis. Paget's disease is particularly characterized by this elevation of the alkaline phosphatase. The diagnosis can be confirmed in these patients with a bone scan and a mandibular biopsy. And the treatment for this patient would be a bisphosphonate, which would normalize, in this case, normalize the serum level of alkaline phosphatase. Now, obviously, an earlier diagnosis and treatment might have limited this mandibular hypertrophy and pain that this patient experienced. Some background on Paget's disease of the bone. It's a chronic disorder that can result in enlarged and misshaped bones. It's named after Sir James Paget from the UK, described many years ago, affects 1.5 to 8% of the population, with the presentation generally over the age of 55. It's caused by the excessive breakdown and formation of bone, which is then followed by disorganized bone remodeling. Affected bones weaken. This results in pain. The bones are shapes are misshaped. There's fractures and arthritis in the joints near the affected bones. And rarely these patients can develop primary bone cancer, which is known as Paget's sarcoma. Often Paget's disease is localized to only a few bones in the body. The pelvis, femur, and the lower lumbar vertebra are most commonly affected bones. Early diagnosis and treatment is important, and after the age of 40, siblings and children of someone with Paget's disease should have an alkaline phosphatase blood test measured every 2 to 3 years, and then treatment began with a bisphosphonate. So remember, Paget's disease can affect bones in many different areas. The picture I showed you was a malformation because of mandibular hypertrophy of the jawbone, and that coupled with the elevated alkaline phosphatase, particularly the bone-specific alkaline phosphatase, points you in the direction of Paget's disease. Question 26. This is a 30-year-old patient who returns with fever after a visit trekking in several sub-Saharan countries. He has a high fever, 39.5 degrees centigrade, low to normal blood pressure, and lethargy. He complains of a stiff neck and photophobia. The rash has begun 2 days before the visit to the emergency department and 8 days after his return from sub-Saharan Africa. The most likely diagnosis is A, erythema multiforme, B, meningococcal meningitis, C, Henoch-Schönlein purpura, or D, microscopic polyangiitis. So these are the options. This is the picture shown here, which is of this rash. So the correct answer is meningococcal meningitis, and this is that typical rash in someone who is quite ill and is going to get sicker if diagnosis management is not made quickly and treatment started. Now, in this differential diagnosis, I mentioned erythema multiforme. This is an acute self-limited and sometimes recurring skin condition that's considered to be a type 4 hypersensitivity reaction, which is associated with certain infections, medications, and other triggers. Henoch-Schönlein purpura, on the other hand, you see this in the lower extremity in this patient, is a systemic vasculitis with immune complexes depositing and when you look at this under immunofluorescence, you see IgA staining. In the skin, the disease causes palpable purpura, but you can also observe, or patients can present with kidney and joint involvement and abdominal pain. The abdominal pain is generally due to a small bowel vasculitis. So the classic triad in HSP is purpura, abdominal pain, and arthritis. And clearly, this is not what this patient had. This is now another part of the differential, which is microscopic polyangiitis. It's very similar to the lesion you see in Henoch-Schönlein purpura, which also is a small vessel vasculitis that involves arterioles, capillaries, and venules. In this patient with microscopic polyangiitis, the constitutional features are also quite prominent: fever, anorexia, weight loss, and fatigue. And this is often is a prodrome that may last for several weeks to months and then followed with the development of rash. These patients also have renal involvement, glomerular involvement with rapidly progressive glomerulonephritis, which is defined as a fairly rapid declining kidney function with at least a doubling of the serum creatinine, presence of hematuria, which can either be gross but often is microscopic hematuria, presence of red cell casts or dysmorphic red cells. These patients may present with rheumatological manifestations, myalgia, arthralgias, and arthritis, with GI manifestations, with small vessel vasculitis of the bowel, particularly small bowel, abdominal pain and GI bleeding, lung hemorrhage, and peripheral neuropathy. So getting back to meningococcal meningitis. Meningococcal meningitis is what this patient that we presented originally, that picture you saw, has. This is a gram-negative Diplococcus from Neisseria meningitidis. These patients present with intense headache, fever, nausea and vomiting, photophobia, stiff neck, lethargy, altered mental status, and rash. So that's meningococcal meningitis. So they have a meningitis from a bacterial infection, and the syndrome is really quite severe. Quite frequently, these patients might develop meningococcal septicemia with a rapid circulatory collapse and a hemorrhagic rash, which I shared with you in the original picture. It's a much more severe but less common form of meningococcal disease, something you need to be very vigilant of. Lumbar puncture is done. The CSF usually confirms the presence of meningitis. The typical CSF abnormalities in meningitis of this type include an increased opening pressure greater than 180 millimeters of water, pleocytosis of polynuclear leukocytes, a decreased glucose concentration, and an increased protein concentration. Culture of the CSF and blood specimens is important to identify the bacterium, the Neisseria meningitidis, and also the serogroup of the meningococcus, as well as to determine the susceptibility to antibiotics. Nowadays, you can also use a PCR assay for confirmation of the diagnosis. This is the meningococcal belt. You see sub-Saharan Africa where it is particularly common. So keep that in mind when you hear the travel history. So the next question is question 27. This is a 19-year-old man who presents with a 10-month history of Raynaud's phenomenon, fever, abdominal pain, and hypertension. On examination, he had multiple subcutaneous nodules on his forehead, and his blood pressure was 150 over 100 millimeters of mercury. The lab findings included a normal urine sediment, an elevated SED rate, mild anemia, and leukocytosis. But importantly, he had negative tests for ANCA, for hepatitis B surface antigen, and for hepatitis C antibody. So you see an arteriogram on the left-hand side of the kidney. So this is, you can see the kidney outline. You see the renal artery, and then these are the branches. And so the question on that we have is regarding the diagnosis suggested by these findings on his angiogram. A, Takayasu's arteritis. B, Wegener's granulomatosis. C, a paraganglioma. D, systemic lupus erythematosus. Or E, polyarteritis nodosa. So the correct answer is polyarteritis nodosa. And so the arteriogram, the angiogram here reveals multiple microaneurysms involving the parenchymal branches of the hepatic, have involved, when you look at the big angiogram of the hepatic artery, of the splenic artery, and the renal artery, what you see here is of the renal artery. This is the kidney. You see these microaneurysms, which are absolutely pathognomic. So the biopsy of the subcutaneous nodule revealed the necrotizing inflammation of medium-sized arteries and vasculitis in the renal biopsy specimen. These are findings consistent with the diagnosis of polyarteritis nodosa. And so the patient was treated with corticosteroids, and this resulted in resolution of his symptoms, including the skin nodules, fever, and abdominal pain. Multiple aneurysmal dilatations of up to 1 centimeter in diameter involving bifurcations and branches of small and medium-sized arteries are characteristic of patients with polyarteritis nodosa. So keep that in mind. You get presented an angiogram of the kidney, look for these telltale microaneurysms, but also look for the other signs of a vasculitis in a patient like this. So quick background on polyarteritis nodosa. Classic polyarteritis nodosa, PAN or CPAN, is a systemic vasculitis characterized by necrotizing inflammatory lesions that affect medium-sized and small muscular arteries, preferentially at vessel bifurcations. This results in microaneurysmal formation, aneurysmal rupture with hemorrhage, thrombosis, and consequently organ ischemia or infarction. First described by Kussmaul and Meyer in 1866. It affects the skin, joints, peripheral nerves, the gut, and the kidney. It affects skin joints. It can affect the joints, peripheral nerves, gut, and the kidney. That's just a repetitive. So question 28, a 48-year-old woman is admitted to the MICU, status post a multi-vehicle accident, experiences concussions, rib contusions, lacerated spleen, requiring emergent splenectomy. During surgery, she requires 6 units of packed red blood cells, 6 units of platelets, 4 units of FFP, and the chest x-ray shown. On 100% FiO2, her O2 saturation 92%. Her arterial blood gas shows a pH of 7.28, a PCO2 of 46, a PO2 of 66. The most likely diagnosis, and now you're given the choices, but before you consider these choices, this is the chest x-ray shown here on the PA view. The options are A, acute interstitial pneumonia, B, severe ARDS, C, multilobal community-acquired pneumonia, D, all of the above, and E, none of the above. And the correct answer is severe ARDS. So severe ARDS is due to trauma, blood contusion, transfusion-related lung injury, but could also be associated with COVID-19, given particularly the current context. Annual incidence of ARDS is 60 per 100,000, much higher in the COVID era. About 20% of MICU admissions with respiratory failure have ARDS. Obviously, in the midst of a pandemic that we currently are experiencing, these numbers are a little bit skewed, will be skewed more in the direction of COVID-19 related ARDS. Many causes, the most common are sepsis and pneumonia, are obviously subject to what comments I made about COVID-19 as well. Diagnosis, you get an acute bilateral infiltrates hypoxemia, but you also see normal left atrial filling pressures if you do a Swan-Ganz catheterization. There are 3 different types of ARDS: mild, moderate, and severe, and these are defined by the ratio of the PO2 to the FiO2, and you see that there are 3 categories: mild, moderate, and severe. This schematic shows you a normal alveolus on the left-hand side, an abnormal alveolus or an injured alveolus on the right-hand side during the acute phase of ARDS. And you see what ends up happening is you get activation of neutrophils, you get a release of a variety of different cytokines, pro-inflammatory cytokines, and you get this protein-rich edema fluid that inactivates surfactant. You also get sloughing of the bronchial epithelium, and really this disease is quite a severe disease that can make patients really quite sick. ARDS, the only key thing I think is relevant to the boards that I want to share with you at this point is that there is a Berlin definition, the timing of which is classically defined using this definition is within 1 week of a known clinical insult. Now remember that COVID-19 generally you get, it doesn't fit the Berlin definition. You often see ARDS more than 1 week, maybe 9 to 12 days after the original presentation. So just keep that in mind. It's sort of a little bit more of a latent presentation. Chest imaging, similar between ARDS from non-COVID causes versus COVID causes. You see these ground glass opacities, bilateral opacities that are not fully explained by either effusions, lobar or lung collapse, or nodules. The origins of the edema not fully explained by either cardiac failure or fluid overload. You often need an echocardiography. You may need a Swan-Ganz catheter. We discussed the classification of mild, moderate, and severe based on the ratio of the PO2 and the FiO2. This is a chest X-ray in COVID-19. You see the manifestations of bilateral shadowing, which is often seen in 70+% of patients. This ground glass opacities that are typical. The disease can be unilateral in about 1/4 of all patients. You can also see local patchy shadowing. Interstitial abnormalities are much less common, and pleural effusions are much less common, and I share with you the reference here. The last question, question 30, is a 19-year-old woman who presents to the emergency department with a 10-day history of intermittent odontophagia, which is throat pain, voice changes, and fever. Before her visit to the emergency department, she was treated with azithromycin and prednisone for pharyngitis, and subsequently with a two-day treatment of penicillin and a tapered dose of prednisone, otherwise healthy. Examination reveals bilateral swelling of the soft palate with a midline uvula pushed anteriorly. You can see that here, the midline uvula is pushed anteriorly. And so the options that we're asking you to consider for the diagnosis are A, Ludwig's angina, B, glossopharyngeal nerve palsy, C, pharyngeal gonorrhea, D, bilateral peritonsillar abscesses, and E, infectious mononucleosis. The correct answer, bilateral peritonsillar abscesses. Let's look at this. The arrows show the abscesses with the swelling here of the tonsils, and below this, if you if you put a needle in there, you find pus. So the bilateral swelling of the soft palate with the midline uvula pushed anteriorly. A CT of the neck after administration of the IV contrast showed these bilateral peritonsil abscesses. This scenario is most consistent with the diagnosis of bilateral peritonsillar abscesses. So that's it. Thank you very much for joining me, and good luck.